Hello again and welcome back. Moving on with the agenda for our board meeting in public this morning, I'd like to hand over to Stuart to talk about the board assurance framework. Stuart.
Thank you, Anita. So since May board, the 24-25 BAF has been fully developed. One point to highlight is that the financial risk 3 has been broadened following FPPC feedback to include the system risk. So it's just checking with the board that you're happy with the fully worked up 24-25 BAF. That's point number one. Point number two is we had a really useful discussion at Audit and Risk Committee yesterday. At the bottom of the cover sheet, I set out some improvements. There were two additional improvements that we discussed at Audit and Risk Committee. So one is to introduce a spotlight for 2 BAF risks at each board. So and also asking executive leads to present their risks to the committee to help drive mitigation and clarity on assurance levels. So if I could just take feedback from the board, are you happy with the 24-25 BAF as set out and with the proposed improvements to the BAF?
Thank you, Stuart. Any questions, comments on those two proposals? A spotlight on 2 BAFs each time, and to get the executive, not quite sponsor, but I can't remember the phrase you used, but basically to talk about our mitigations and so on in those areas. Are we comfortable with both those changes, and are we comfortable with the BAF as it stands today? Clearly it's a living document, so it will change. It may well change next month or the month after, but as it stands today, are we comfortable with that BAF? I don't see any dissent, but I do see a few nods. Stuart, thank you. It seems like you've done your work well and obviously socialised this with board members, so I don't think there were any surprises here. So thank you for that. And yes, we are happy to proceed with the BAF as it is. Thank you. Right, moving on, and thank you, by the way, for also doing that in such a speedy way. Right, moving on then to summary learning from deaths. Justin.
Thank you, Anita. I'm really grateful for the chance to present this. I would be grateful if people would take a look at page 94. That's our major risks around deaths as an organisation. And I'm just going to whiz through those fairly quickly. The first risk on there is around the SJR Plus tool, which is how we analyse deaths. That was a risk until this week. In fact, we've now resolved the issues around how we use that tool, and we now have it available and we can get on with the work we need to do. The second risk on there is around the HSMR and SHMI alerts around cardiology, and board members will be aware that we've talked about this on a number of occasions. We continue to look at this in detail. The major issue seems to be around coding with this. I'm not convinced that there is a safety risk within cardiology, but clearly it's something that we're going to continue to look at in great detail. We have talked before about the implementation of PSERF. It's making really good progress. But again, in terms of how we look at deaths, it's really important that we get that right. And likewise, Enhance. We heard at last Quality and Safety Committee the progress that's been made with Enhance, which is our way of notifying incidents and significant incidents within the organisation. And again, there is progress there. The medical examiner integration goes forward another step in September. So in September of this year, all deaths across the UK will need to go via a medical examiner. And that means that whilst our medical examiner associated with the organisation has been picking up all of the in-hospital deaths for some time, they will now have to pick up all of the community deaths as well. Many of the GP surgeries are already working closely with the medical examiners. There are a few who are not, But we will also need to become the medical examiner office for the local private hospitals. And we've started talks with those organisations, but that's going to be something that we have to take on board as a trust. And the final thing on our risks is the work we've been doing around ovarian cancer and the SACT 30-day mortality, and board members will be aware of the review that we've had and the subsequent work that we've done on that, and that it's an area that we continue to pay really close attention to. And you may or may not be aware that we've been working very closely with Professor Jonathan Lederman from UCL, who's been sitting in on our MDTs in order to ensure that we've got our quality right and in order to ensure that there is a degree of consistency. Anita, do you want me to take a question from David or to carry on and finish the report first?
Why don't you finish your report and then we'll take all the questions and comments at the end.
Okay, so very briefly, I'd just like to take you to page 99 of the pack, which is then a list of the things that we're doing as improvement activities. So I've already spoken about the work around ovarian cancer. I've talked a little bit about the work that we're doing around cardiology. The other two things on 99 are the work on sepsis. So we are well placed in terms of HSMR with regard to sepsis, but sepsis is complex, and we will talk when we come to the IPR about sepsis 6 compliance rates. There is probably an interrelationship between sepsis 6 compliance and our C. diff rates. And that's really difficult because we know that sepsis 6 pushes us to start broad spectrum antibiotics very early in the patient pathway. And for many patients, that's the right thing to do. But when you then look at our C. diff analysis, there are concerns that we may be starting broad spectrum antibiotics on too many patients. So there's almost a clashing of two national agendas, and getting this right is hard and it's nuanced. And then the final piece of work for improvement activity on that list is stroke. Board will be aware that we're on a SNAP-B at the moment. There are a number of challenges around stroke, and there are also some challenges on mortality within stroke. And that's an area that we're working hard on at present. And the final thing on that list then is the emergency laparotomy work. The board will be aware that there is a national programme looking at the outcomes of emergency laparotomies, and that's something that we're also looking at closely. And I'll stop there if that's okay and take questions.
Thank you, Justin. David.
Thank you very much. Well, first and obviously, we do look at this paper regularly in clinical governance, so I'll just make that observation. Secondly, I do attend the mortality review group whenever I can. My clear impression is that the clinicians are strongly engaged, and there's been a lot of real meaningful work on the cardiology issue. So I've got two very quick questions. Cardiology does pop up ever so often and has done it as long as I can remember. I have never seen any evidence that our services mortality review in any way whenever I can. It's just an open question. Are we just going to continue reviewing it as we do, which I do believe I can say to the board is very thorough, or is there anything else we should or need to do on that, Justin?
So I think there are a number of complexities around the cardiology services that we offer, not least that we offer PPCI as a district general hospital. And I think that we've talked previously as to whether that probably adds to our mortality data a little bit. I don't feel at the moment that we need to do more externally around our cardiology. I'm very happy to hear others' views on that, but I don't have significant concerns about the service, and I don't have significant concerns about the data that comes from the service. I think one of the things that's helpful to bear in mind is that if you look at our HSMR, our SHMI, and our overall mortality rates, all of those are favourable. And we had some really positive comments around our length of stay and also our readmission rates made at the GIRF meeting yesterday, which was really helpful to hear. And when you triangulate those three things together, we are not seeing excess mortality, we're not seeing excess readmissions, but we also have a length of stay that is comparable with the best organisations in the country. So I think when you triangulate those three bits together, I am not concerned at the present time about cardiology, and I don't feel there is a need for it for an external review. But as I say, I'm really happy to listen to others' views on that.
I'm absolutely not pushing you for one. I've never asked the question. I just wanted to hear in public what your view on that matter was. So thank you. May I just briefly ask a second question? I recognise that coding is really always a critical element. The way we do this nationally changes, and it's sort of reviewed every year or so. Our mortality statistics, I would say, are probably better than favourable. They've been really very good, which I find incredibly encouraging. Will the latest mortality mechanisms alter our figures?
So I think what you're talking about is a bit of a rebasing. So
yes.
Some of the data will be rebased over time because actually the national average, which should sit at 100, is not 100 at the present time. So we work with an organisation called CHKS who help us with our data. And they are planning a rebasing, and that will change the numbers that you see slightly. But what it won't change is where we sit in comparison both to all of the trusts in the UK, but also the peer group that were assigned based on the demographics in our organisation.
Thank you, David and Justin. Teresa.
I just wanted to say, Chair, if I may, thank you to Dr. Daniels, because actually what I'm very impressed with, I don't get to all the mortality reviews, but I do get to quite a few, is how well linked in the safeguarding aspects are to it. And a good example for me is around, obviously, patients with learning disabilities. As we know, their outcomes potentially, all the research data tells us, can be challenged, but a really clear line of sight into the ledger reviews and our mortality committee at the hospital. And I think seeing that link to safeguarding gives us absolute comfort in some ways that we are addressing and being proactive around any potential learnings. So I just wanted to highlight that point, Chair.
Thank you, Teresa. That's helpful. Nina.
Thanks. I was just a question really. So for as long as I've been in the trust, that cardiology I think has been kind of alerting. And I was just wondering, Justin, do you think that is just going to be a consistent issue going forward? So we don't need to worry about it, or it? Because I'm just trying to figure out if it is a coding issue, when can we fix that coding issue, or is it never going to be fixed? And then is it just a false alert? Because at the minute, I feel like it comes up all the time. I don't have the trend, obviously, but it would be good to get a trend over time, maybe, to see if it picked up at a certain time and whether we can just be not as concerned about it because it's just a strange mix that's created that alert.
I think you probably need a more detailed answer than I perhaps can give now. Can I go away and do a little bit more work on this and come back to you?
Thank you.
Thanks, Justin, and yes, a good question, Nina. Jonathan.
So, Justin, you touched on sepsis, and we haven't got to the IPR yet, but when we do get to it, we'll see that our sepsis performance, our compliance, is less than it used to be, and it has been for a while yet. So, if there's this conflict between sepsis and C. diff, I'm just wondering about what guidance. How do doctors deal with that? Are they in two minds, or are they firmly of the view that it should be sepsis over C. diff?
A really interesting question, and one I'm going to struggle to answer quickly, but let me give it a go. We know that there are two main drivers of C. diff. One is broad spectrum antibiotics, and the second is use of proton pump inhibitors, so drugs like omeprazole or lansoprazole. We know that we have a very high risk population for C. diff. Many of our patients come to us from care homes. Those patients are often on PPIs as part of their general medication. And when they come to the hospital, the sepsis 6 would guide us in many of those patients to starting broad spectrum antibiotics. I think the response has to become a little bit more nuanced, and we have to think in a little bit more detail about the patient in front of us and what they really need. Clearly, we must not miss sepsis. Patients die of sepsis if we get this wrong. But it's not as simple as saying that all patients who come whose triage scores suggest sepsis will do better with broad spectrum antibiotics. And I guess that's where the difficulty lies. We see very high volumes of patients through our emergency department and our urgent treatment centres, and it's giving staff the time to make those decisions. And there may be some patients where it's better to see what their inflammatory markers are rather than starting antibiotics straight away, but that will then affect our sepsis 6 results. When you're looking at the sepsis 6 results, there are 2 groups of them. There are the group from ED, and actually we're not doing badly on our rapid starting of antibiotics in ED. And then there are the group on the ward. When you look at the denominator, the actual number on the ward is relatively low for the number of people who qualify for sepsis 6. And therefore it's not unusual for the percentage to be low. And I think in the last month or the previous month, percentage was sitting at 50%, but actually that meant that 2 patients had had their antibiotics outside of the 1 hour time scale that we aim for. Whereas in ED, the numbers are much larger. So it would always be the ED sepsis 6 number that I would be more interested in looking at. But as I say, making those decisions is often not straightforward, and I would rather we made the right decision than we made the decision rapidly. That's a sort of answer to your question. I'm happy to pick up offline and try and give you a better answer than that, if helpful.
That was helpful. I suppose maybe the standard we try and keep ourselves to is maybe not in the right place, but anyway, that's not for me to say.
Thanks, Justin. Last question, Peter.
Yeah, thanks, Anita. Justin, I just wondered how well we were doing in relation to NELA on a sort of national scale.
So we are doing reasonably well with NELA. We're not at 100%.
Justin, sorry, could I just ask, for those who might not know, who might be listening, could you just say what NELA stands for, please?
Yes, I could. It is the emergency laparotomy audit that we do. So we know that patients who come into ED needing an emergency laparotomy are often our sickest surgical patients. They often have very significant problems with their bowels, and we know that the mortality in that group can be high, and that's the reason why there is a national audit looking at it. We're doing reasonably well with those patients. I think that when you look at the data, you have to remember that the patients we treat at Eastern North Hearts on the whole are older than the average population in the UK, and a high degree of them are very old. So I review the NELA data, but I also review our fractured neck of femur data every month. And when you're looking through those lists of patients, the age of the patients coming in requiring that surgery, and the comorbidities that obviously go with that are significant. So the short answer is I think we are doing okay with our NELA data. I think there's always more that we could do.
Thank you. Thank you, Justin, for that report, which is for noting. I don't see any other hands, so thank you. We'll move on. Right, moving over to the integrated performance report. We're obviously, some really good questions and some really good discussion here. We are running significantly behind time at this point, so if we can kind of be crisp and concise, we want to have the discussions, but we maybe just be a little mindful of the time so that we can give enough time to all the items. So, integrated performance report. Who's going to be kicking this one off today?
Yeah, I'll kick it off, Anita, if that's fine. So, for colleagues who are joining or observing the board for the first time, this is an item whereby the board looks at its key performance indicators through 4 different kind of lenses, focusing on quality, operations, finance, and people. And there's a wealth of material and data here that does support us in those conversations. I think in terms of the structure of this month's report, you'd see there's a slight development, and on page 101 we have a summary sheet on there that just calls out some of the key messages across those kind of domains. So we'll continue to develop that as we come into future months. But if I could first off start with kind of Teresa and Justin, maybe calling out some key quality indicators for us.
Thank you, Martin. I'll be brief, absolutely. So I'm going to start with some of the positives, actually. If you look in the IPR chart, what you'll see is that our rate of falls is actually starting to really move in the right direction. So falls prevention in place across all of our wards and departments, but we can't be complacent because one patient fall is one too many. We're also seeing a net reduction in hospital-acquired pressure ulcers, but we are seeing a net increase in community-acquired pressure ulcers. So just to highlight to the board that is something we're seeing just now. We've talked about C. diff. One of the bits that I'm quite pleased about is that we are screening every patient who comes through our ED. So we're not waiting days and days to actually make sure that lab test goes off. But I think just our medical director has talked us through some of the challenges there, but happy to take questions. We continue to have our sepsis task and finish groups, multidisciplinary, supported by a consultant and senior nurses. And then just a couple of quick points. VT sustained improvement again on VT level 1. But a watching brief on VT assessment 2 as well is underway. Patient engagement, just a couple of quick points from me really. Outside of FFT, seeing really good engagement at the Maternity Improvement Committee, where we have patients presenting now as well as staff. At the Dementia Committee, where we also have engaged users and carers, and also engaging with Health Watch around our friends and family complaints, etc. And good news on the PALS front, that we're seeing our PALS reduction of numbers there, with some interventions around nursing staff being based in the PALS office to help support those patient concerns. And we'll just a final point from me around the quality of care aspects. We have all of those indicators are fully embedded in our fundamentals of nursing care that Kevin touched on earlier, Chair. Happy to hand over to Justin now.
That would be great. What I'm going to suggest, given time, is if we'll take all of quality, we'll just pause then for David as chair of QVC to comment, and we'll take them in chunks, as it were, and hopefully then if there are additional questions, we'll take those too. So yes, Justin, please.
So just following on briefly, I think our data on venous thromboprophylaxis, so that's prevention of clots, is looking good, and we are seeing a gradual increase in the uptake rate. We're working really hard with individual wards where we can see that there's a problem with that, but we're making good progress. In terms of our maternity metrics, most of those are going in the right direction. Our overall spontaneous vaginal delivery rate is lower than it has been. And I think that's part of a national trend with more and more women either needing or opting for caesarean section. That's not something I think that we can change as an organisation, but it does have an impact on morbidity and mortality, and it also has an impact on workload within the department. And then our overall mortality data, I've spoken about this briefly in the previous paper, is going in the right direction. I don't have significant concerns about it at the present time, but I'm really happy to take questions.
Thank you. Thank you, Teresa. Thank you, Justin. Can I ask David, as chair of QSC, to make any additional comments?
Thank you, Chair. I can be brief. I do have a list in front of me of things that I wanted to touch upon. Actually, we've discussed many of them already. The VTE, which is about statistics rather than necessary, safety or performance. We've mentioned under learning from deaths, and the others are in my escalation report. So I'm quite happy to leave it at that. Thank you.
Thank you, David. Any other questions from anyone else about the quality aspects of the IPR? I don't see any hands, so thank you very much. Can we move on to operations then? Who's taking us through that bit?
That's me. Thank you very much. For anybody that doesn't know me, I'm Lucy Davies. I'm the Chief Operating Officer here, and I'll be brief. On our urgent and emergency care performance, we're looking at May in this report, and our 4-hour performance was not as good as we would have liked, but I'm glad to tell the board that in both June and so far in July, it is moving up slowly but surely, and we have a very full programme of improvements, which is supported by the GIRFT visit we've already referred to that took place yesterday, the GIRFT and ESIST visit yesterday. I'm confident that we will continue to improve through the course of this year to this year's target of 78% by the end of March. You'll see in the cancer section that we achieved 2 of the 3 targets, just very slightly missing the 31-day target, which is unusual for us, and I think due to short-term both sickness and some recruitment timescales in the radiotherapy team, which I'm confident we will recover to get back on our trend of being compliant with that target going forward. With RTT, referral to treatment times, which is elective waiting times, we are on track to achieve the target of a maximum wait of 65 weeks by the end of September in all but community paediatrics, where we have a very challenged position that the board are aware of, and lots of work going on, and a more detailed report in part 2 to come on our progress against that with our system partners. And with diagnostics, again, an area of significant focus for us this year, and both having done much more detailed demand and capacity planning, instituting a much more focused regime of monitoring progress on those waiting times. And we've seen only 1 point on the process graph, but a little green shoot of a reduction in the number of patients waiting over 6 weeks in the last month reported there. Stroke, finally, our stroke national audit programme rating, as the board knows, has improved over the last year by 3 sections in their rating, but we need to take account that there are going to be changes to the data set from the 1st of July, which is likely to mean, alongside some recruitment challenges that are persistent in our therapies team, to mean that our current rating of B may be at risk from Q2, and more detailed work to be done on that. Thank you. I'm ready for questions.
Thank you, Lucy. Great. Can I call on Karen as Chair of Finance, Performance and Planning, if she has any further comments?
Yes. I think actually I'll just, if it's okay, identify a couple of the areas that actually come through in the alerts, so that I don't need to pick those up later. So the first is we've had some really good reports at FPPBC on the emergency department and all the good work that's been done there around the UTC, which has been excellent. But as you would expect us to do as well, we've been challenging about how we are actually going to achieve the performance standards that we would like to achieve. We've had a positive response, and I know that trajectories are now being drawn up, and we are aware of all of the work that's going on in this area, and I think there's a report in part 2 where we're going to look at it in further detail. We also have flagged up and challenged around community paediatrics. It's important to say that a lot of this sits at system level, and that we are working quite closely with the system to try and reach a route forward. But from a non-exec's perspective, having a clear line of sight on when we are going to have a solution actively in place is quite hard to see at the moment, but I know the executives are working hard on it. And then the final item was to commend the piece of work that had been done on command and capacity around our diagnostics. It was a really helpful piece of work. It had flagged up one area that we wanted to alert the board on, which is to do with MRI capacity within the trust, and work we know is being taken place. So we've got some assurance now that work is taking place to identify that capacity externally. So I think those were the 3 items I wanted to raise.
Thank you very much, Karen. And I know we'll be hearing from you shortly on the finance, but we'll come back to it in a moment. Right then, I don't see any other hands on the operations. So moving on then to finance. Martin.
Yeah, thanks, Anita. Obviously, very early days in terms of the new financial kind of year. The board will be pleased to know that we have finally confirmed 24-25 financial plan with NHS England, and that's for a £1 million kind of surplus on there, and that sits within the context of a rather challenging kind of system position, which is a net £20 million deficit plan for Herts and West Sussex as an ICS on there. In terms of kind of month 2, we're broadly on track at the moment. We had anticipated being slightly in deficit at this early stage in the year to the tune of £1.1 million, and that's broadly where we are at the end of May. Having said that, there are some early challenges emerging within our financial position that we'll need to be aware of and act in response to. Our ERF delivery has been a little bit slow, kind of coming off the mark in the early days of this kind of financial year, and we're taking kind of some steps in terms of remedial action to bring some capacity kind of online to hopefully address that. And similarly, we have, perhaps unsurprisingly, a number of kind of pay pressures that have emerged this early stage in the year. Again, divisions are working and focused on how we can address that. Big financial target for the year this year, some £33.8 million. On there, we have a fully identified plan against that. Obviously, a key part of management and indeed finance committee work across the year will be monitoring and ensuring that we deliver against that in the same fashion that we did positively last year. So there may be just a couple of the key headline messages I'd like to call out at month 2.
Thank you very much, Martin. Karen, anything from your committee?
Yes, just to add again the concern of the committee about the position, the financial position across the ICS, and obviously that does interrelate quite strongly within our own financial position as well. We are aware of all the good work that was done last year at divisional levels to improve the position on SIPs, and we achieved our SIP performance last year, but we do have a challenging position this year. The only thing we really wanted to highlight was that we were doing so well at the end of last year that we were slightly disappointed in the first 2 months of this year in that we didn't quite get off to the start that we'd wanted. So we think that everybody is doing I think the thing is with finance, it's very easy to slip your attention off it. And once you slip your attention off it, it can easily move away from you. So we would just like to encourage that proactive, I suppose, and active engagement at all levels, which we saw so effectively last year, just to make sure we do really keep on top of it.
Yeah, thank you, Karen. Any further questions or comments for Martin on the finance? No, I don't see any hands. Thank you very much. So then turning to people, Tom.
Yep. Hi, just a few highlights from me. You will see that the vacancy position has slightly stepped up over the last 2 months. That is a bit more reflective around kind of setting the establishment for the new financial year. And we've just heard around kind of certainly our plans around ERF work that we need to commit to, and that means that we're getting some recruitment going to focus on that. From a positive point of view, although we're sitting over 8% at the moment, we do think that with all the work we've done, particularly focused around registered nurse recruitment, that by September, October, we should be down to none, if barely minimal, vacancies for our Band 5 nurse positions, and that's because we've had great success with our newly qualified, newly newly trained nurse cohorts, and we've done a lot of work, particularly promoting around theatres, recognising that we've got some expansion work going on there as well. So the signs are positive with the recruitment that we have in place at the moment. I do think it's worth just highlighting the triple lock processes that we have in place at the moment. That is set from region down through system down to us locally. So we have in place local resource control panel that will review all vacancies that go onto our system, and we are being very robust in checking the funding arrangements, the vacancy arrangements. Is there an opportunity to do anything differently? How is this supporting us delivering our SIPs? And I think that is proving to be fairly effective. Certainly the things that we're having to pass through to the second stage of the triple lock, the feedback is that the information is good, and we're getting good feedback about that, and the majority of the posts that we have put through are going through. Lots of focus around training, and again, disappointingly, we've just dipped below our 90% target. So I think we do need to refocus efforts on that. A key part to that is around moving and handling and resus, for which we have to do that face to face, and there's lots of work going on around kind of identifying good spaces that we can use to get as many people trained in those areas as possible. A brief touch on Grow Together reviews. We've just reopened the window, so we expected a little dip down at the start of the year, but I really do think that will ramp up, and by the end of August we should be in a very good place with that. But most importantly, it's about the effectiveness of those reviews, and we talked about the importance really of setting clear expectations, objectives, supporting with people's development, and helping with people's well-being, and the Grow Together reviews and the ongoing one-to-ones is fundamental for that. We do think the improvement in some of that work has really helped contribute towards our retention rates, which are exceptionally positive, I would say, with sort of 9.8% against previously an 11% target. We've kind of decided we need to stretch ourselves a little bit more, and that will go down to 10.5, but we are ahead of target on our retention figures, and we hope that continues. I mentioned really, as I referenced earlier, our management competency framework is now a couple of months into action. We've got the early bit of feedback from that to say that people are really benefiting from it, and actually we're way oversubscribed, particularly around kind of skills in general kind of general management related to employee relations and casework, which we're really pleased to see that people are very engaged by, and shows there was a real need there. And if you don't mind, Chair, I will just say that we're really proud that we've been nominated and shortlisted for our virtual assistant that we've got in our HR services called Inquire. So great recognition from the HPMA that we've been shortlisted for innovation.
Brilliant. Thank you, Tom, and congratulations to the team on that one. Val, Chair of People and Culture, any thoughts or comments?
Thank you. Yeah, a few words. We had the April data last time we met, but it's really good to see the sickness and retention metrics, the underlying way we're working with our teams and staff and recruiting from within, absolutely superb. Just to add a different flavour to this discussion, yesterday I heard about a consultant who'd been coached by the people partner in the department to have those good conversations about long-term and sickness and return to work, flexibility of working, and had just learned a huge amount, had confidence and success with applying that. So I applaud the people partners and their role in divisions. And just to say, in our committee, we want to give them a rotational role in experiencing the committee discussions, recognising their power at working with staff at that level in the future. The headcount issues, Tom's mentioned the constraint on the triple lock. Or, we have recruited to develop our urgent care centre, and we will be recruiting and quite considerably agency around some of the IT changes, I believe. So this drive to get our headcount down, you have to look at the nuances, I think, behind that to understand where we are on that. And the triple lock constraints can be, extremely frustrating. They're clearly to have scrutiny over what we do, but the effort to comply with that and respond to that is going to take its toll. And likewise with mandatory training, We had the example in around maternity, Amanda, where, you know, if you added up all the compulsory, and for very good reason, that the training that we need to demonstrate, you know, I won't quote a statistic, but it's eye-watering release of staff over a period of time to get to that level of full training, and therefore we have to look very carefully about how we manage that. So that's just some of the dilemmas and nuances around the metrics that are in the performance report. Thank you.
Thank you, Val. One hand, Jonathan.
Yes, question for Tom. Given turnover in nursing and given the national shortage of nurses, does it make sense to cut off the international recruitment completely? Because last time we did that, we found we had quite a deficit and we had to go back and start all up again. That was the question.
It's a good point, and it's something that we keep under review, Jonathan. I do think at this stage it's proving to be the right thing to have stopped international recruitment, particularly as that our newly qualifieds that we've just recruited through coming through. We've got some that we are still actively trying to place, put it that way. So that's a much better position than I thought we'd be. We will place all of them, but you know, we've got every vacancy covered at the moment based on that trajectory, and I do think that is mostly because our turnover has been better than maybe expected, so we hope it stays that way, in which case I don't think we will need to go out for international recruits for general nursing. I still think there's always space for international recruitment, particularly in hard to recruit and more specialist areas, and that's the bit that we just need to be agile enough to be able to respond to. And I think we've kept our services so that we can step them up easy enough should we need to, and we've kept good relations with the people that we work with overseas to support us with that as well.
Thank you, Jonathan and Tom. Final question from Peter.
Thanks, Anita. Two what I think are very positive points. Recently, virtually every newly qualified midwife from the University of Hertfordshire who rotate over a number of hospitals all applied to come and work at the Lister. And I think that's worthy of mention. And the second positive thing is in recent weeks, I've chaired 2 panels for consultant medical staff. And I have to say, in both of those panels, the quality of applicants was right out of the top drawer. And I just, as I say, also think that's worthy of mention.
Thanks, Peter, and I would agree with both those comments. I've noticed the same. So yeah, well done to the whole team. Thank you very much for that. We note the integrated performance report, and speaking personally, I really like the front sheet. I think it really does help focus the mind. I'm sure there will be further development of it, but I think it's a great starting point. So thank you. I certainly found that very helpful. Right. Oh, Martin. Oh, no. Okay,
an erroneous hand, sorry.
Okay, fine. All right. Right. Let me move on then to maternity. Is it Douglas? Is it Amanda who's on to do that one?
It's myself, Chair. Douglas was hoping to join me, but he's running a clinic this morning and he's had to go back to that. So apologies from him. I appreciate we're sort of short on time. So there was just a couple of key things really I wanted to highlight. One is that we're now into year 6 of the maternity incentive scheme, and just to give assurance to the board that we've developed a comprehensive board planner of timelines of when evidence needs to come, mainly to Quality and Safety Committee, but some things that need specific trust board oversight. So we'll be sharing that with you as an appendix to next month's report. But we are making good progress. There is some risk attached to Safety Action 2, which is around digital, the maternity services data set, but we think that we have mitigation in place for that. Which brings me on to my next point, which is the sort of biggest thing at the moment in maternity is that we are due to launch our electronic patient record, our digital EPR, next week. So we're aiming for a go live date, hopefully of Tuesday, all being well, but we're just going through some final processes this week. We have achieved over our target of the number of staff across the multidisciplinary team who've undertaken their training in preparation for that. and we're just in the process of putting together additional support 24/7. That's both by K2, our digital partners, our digital team on site, and our super users to support staff in the weeks following the launch of that system. But a huge amount of effort, and my thanks to colleagues in digital for supporting us through this process. And then the other things I can probably pick up in the maternity safety support programme update. So we had a peer review on the 20th of May, and we had colleagues from NHS England and the ICB and our maternity improvement advisors that supported that visit. They noted a huge amount of progress, and actually myself and Douglas were invited yesterday to present at a national sharing event that has representation from all trusts on the maternity support programme across the country, and there's lots of opportunities for shared learning identified, and we were praised for the progress that we've made. However, there are 3 key work streams that we're still working on. One of those is around systems and processes, particularly related to estates and facilities and EBME, and we're working very closely with colleagues in EBME to address some of the things that have been noted. Looking at the headroom for maternity, and Val mentioned earlier about the training requirements and how we ensure that we've got adequate headroom for training, and looking at that staffing model for theatres and recovery and how the maternity staffing works alongside that. The key message from our maternity improvement advisors is that they think we are ready to start exiting the programme, something that I'm very supportive of, and I think if we can just demonstrate the required progress on those work streams, we'll be in a good place, and that will involve bringing a paper to yourselves as the board with a recommendation to exit the programme. So at the moment we're aiming for September to start that process, hoping that we may be able to exit the programme towards the end of this year. I've included the dashboard, and you've got the clinical quality surveillance framework, and I'm happy to take any questions for any points of on any points of that, rather than going through that in detail.
Thank you very much, Amanda. And yes, yeah, a good report, and thank you for that. Any questions or comments for Amanda? No, I don't see any. So thank you, Amanda. It was really good progress on the inspection. Congratulations to the whole team for everything that you're doing there, and the best of luck for the EPR next week, because I know that's going to be a big transition for the team, but hugely important. So we hope everything goes well. But thank you for all the work you're doing. Even in the last 6 months, the mood of what's happening in maternity has come on leaps and bounds. So thank you for your contribution to that.
Thank you.
Lovely. Moving on then, system performance report. Martin.
Yeah, so I'm not sure what's happened to Anita. The upload of this report seems to be presented in a slightly jaunty angle. So hopefully colleagues have been able to have a kind of read through it. Of course, this is a report from our ICS that was presented at their May board meeting. Although actually most of the performance data included within that is either February or March kind of data. So it's obviously a little bit old and not really particularly contemporaneous on that, but it summarizes kind of key system and provider performance across a number of different domains, kind of UEC, PTL, dynamics, diagnostics, cancer, and of course mental health and community. So I think it's a relatively useful report for us to digest as a board in terms of understanding where our piece of the performance and delivery jigsaw sits within the context of the ICS position. So I wasn't going to call out anything specific kind of from it, just to set the report within context for us as a board.
Thank you, Martin. And yes, agree. I think it's good that it's in the pack. Please, can we do something about the angle of the slides? This is not the first time this has happened. And but once I'd worked out how I could fix my iPad so it wouldn't swivel every time I turned it round, I managed to be able to read it. But it was a bit, it would be great if we could get that sorted for next time. I don't see any hands raised for any questions or comments. So thank you. We note the report. Thank you very much for sharing it. OK, so moving swiftly on then, just to try and wrap up here. So we have our committee report, audit and risk. Jonathan, we've talked about various bits and pieces, but are there any things you'd like to draw to our attention specifically?
Well, I'll take it as read, but there's only one issue that's really outstanding from that report, is that the accounts, our finance team did a great job getting the accounts ready. They're ready to go. BDO sort of worked alongside us, and then they put on their second partner review, and that just slowed it all down, and the deadline for submitting it was missed, and there's nothing we can do about that. And we're just waiting for it to be submitted now for their okay that they're finally signed off on it.
Yes, indeed. I've come across that before, and it's very irritating when it happens. Any questions or comments for Audit Committee? Nope. Thank you very much. So it hasn't yet been submitted. Our accounts haven't been submitted yet. Okay, right. Oh, well, good stuff. Not, but okay. Thank you. All right, moving on then. Finance, performance and planning. Karen.
I've already said most things, but I would like to just add that an excellent piece of work was done on productivity in relation to ophthalmology. And I would like to say that anybody who hasn't had a look at that piece of work, particularly other board members, please do take a look. It shows what can be achieved in relation to productivity. And I've got great expectations as to where we're going to be able to take this work going forward.
Thanks, Karen. Yes, I was fortunate enough to be able to attend that meeting where it was presented, and it was a great piece of work. So I completely reiterate Karen's comments. If you haven't had a chance to look at it, it's worth doing so. Thank you very much. Quality and Safety Committee, David. Anything to add?
Not really. I think the reports there. I mean, I've just touched upon two things we haven't mentioned so far, which is NICE notifications and duty of candor compliance. I'm not sure they're worthy of major discussions. I've just highlighted them as things that we're dealing with.
Right, and you will continue to monitor, because clearly, they are of concern. So they're things that you'll be continuing to monitor. Thank you very much for that. Any questions or comments on the QSC reports? Nope. Finally, People and Culture. No, not finally. Sorry, we've got Charity as well. People and Culture Committee, Val. Apologies.
Yes, thank you. I think we will ask you, Chair, to check the board approved the change of terms of reference for the committee, which are not all it is a change of title, mostly People and Culture. The change of title is significant, and we've had discussions about how to embed our intelligence and data on culture as well as people metrics and other matters that we discuss. So we want to do that in a very conscious way. And as I say, we want divisions to be front and centre of the agendas in driving what their key concerns are around people metrics, but also around culture, and to give that prominence. So that's probably all to say, and hopefully you can approve that change to the terms of reference.
Thank you, Val. To me, a very sensible change of title, and good to see that that's been implemented so quickly. Can I have board approval of that change of name for the committee and the terms of reference? Thank you very much. Approved. Lovely. Okay, Charity Trustee Committee, David.
Thank you. Well, certainly no concerns at all. The charity's doing really well. As our chief executive said, the fun run is just great. I've been 3 times. I think it's actually only happened 3 times. If you haven't been, it's a really enjoyable, relaxed, informal sort of family event. And we had over 500 people there, so I was really pleased to open it. It isn't like other runs my children attend, which are competitive and quite hard going. This is just fun. So to get that number of people on your 3rd event is a tremendous achievement. So my only other request to the board is one I've mentioned lots of times, is just for us all to remember the charity. When we're busy, we tend to forget, but it is a source of, it is a really a good add-on. It makes a difference to our patients, and we're always seeking interesting and worthwhile projects, and of course we're always seeking challenges. So thank you.
Absolutely, it's a really vital part of the trust, and I apologise that I inadvertently also forgot about it just then, but not at all deliberately. No, and some fantastic work going on in the charity. So yes, very well done to the team doing that. Okay, so moving on, you have in the pack the board annual cycle. Does anyone have any concerns, comments, questions on that? I don't see any. Oh, Val.
Sorry, I'm going for the mic or the raise my hand up. Yeah, I just noticed that the Safeguarding and Learning Disability Annual Report I don't think is ticked on this one, and I noticed equally it wasn't on the Quality Safety Committee forward planner. So Teresa, you'll know whether that's probably already in production, but it would be good to QSC and board for a date for that to be set. Thank you.
Thank you. Well spotted. I hadn't noticed that. So yeah, if we can get that sorted, that would be great. Thank you very much. Takes us on to any other business. I haven't been notified of any other, but just one comment I would like to make. As many of us will know, this will be the final board meeting for two of our non-executive directors who will be leaving us in the next couple of months. Jonathan Silver, who is our current chair of Audit and Risk Committee, Val Moore, who's our current chair of People and Culture Committee. Jonathan is leaving us at the end of July, Val at the end of August, but this does mean that we won't be meeting as a board again with them. On behalf of the board and the trust, I'd like to thank them for everything they have done over their long commitment and their passion for our patients, our staff. They have made this trust a better place. They've made our services a better place. They've made our people feel better supported by their actions. So very much our thanks, our very best wishes for you going forward. We won't thankfully be losing Val completely because she will hopefully be taking up a post imminently with ENH Pharma, our wholly owned subsidiary. So we may see her name on various documents at various points, but certainly to both of them, we our sincere thanks and our best wishes for the future. And on that, I will conclude this board meeting. Thank you very much for your attention. I apologise for having overrun. Not good, but I hope you'll agree that we had some really valuable discussions today, and it was important that we let those run. This concludes the meeting of the board in public. We will have a break, and then we have a private meeting, which will commence at 12:30. But for those that are part of that meeting, thank you very much for your time.